All righty, everybody. We're going to go ahead and get started here. My name is Bryson Keith. I'm one of the chief medical residents for the internal medicine department. I have the pleasure today of introducing Dr. Fabian Emura, who's one of our advanced endoscopy faculty. Dr. Emura, after graduating from the Universidad de Valle, completed his general surgery fellowship at the Universidad Nacional de Colombia. Later in Japan, he completed a doctoral program in interventional GI endoscopy and GI surgery at the National Cancer Center Hospital in Tokyo. He started his academic career at the Universidad de La Sabana Medical School in Bogota, Colombia, where he's held many positions, including the position of chief of the Division of Gastroenterology. Throughout his career, Dr. Emura has been actively involved in clinical investigations related to mostly GI tumors. He is the inventor of multiple things, including the systematic alphanumeric coded endoscopy, or SACE, for the early diagnosis of upper GI tract malignancies. He pioneered the NBI colon polyp classification and the endoscopic submucosal dissection technique for removal of gastrointestinal cancers in Latin America. And since 2006, he has introduced funding an uninterrupted annual gastric cancer screening program in Colombia through the Emura Foundation for Cancer Research. Dr. Emura has received many awards, including the Gastrointestinal Endoscopy Top Reviewer Award 5 times, the International Service Award by the American Society of Gastrointestinal Endoscopy, and the Master Endoscopist Award by the World Endoscopy Organization. He's also served as the president of the Colombian Society of Endoscopy and the president of the Inter-American Society of Endoscopy. He is a reviewer for most of the major endoscopy journals and has authored or co-authored more than 80 original articles, books, and book chapters. Please welcome Dr. Emura.
So much. I'm very privileged to be here. I want to thank Dr. Despande for peer reviewing and Dr. Bernal Misrachi. But also to Dan Sussman and Dr. Sunil Amin for making me part of this extremely beautiful, great team at the Division of Gastroenterology, and Dr. Weiss for the precious opportunity to share my research through more than 20 years. So these are my disclosure. Wanna have several topics, wanna read and go over them. Gonna talk principles of cancer tumorigenesis. We'll go also reviewing endoscopic imaging and how it links to neoangiogenesis. We'll talk about the different endoscopic resection methods for cancer treatment. What is actually the importance of a screening for prevention of GI cancer through EGD and colonoscopy. We'll go over what is the difference between premalignant lesions and early cancer. We'll talk about deep cancer or advanced cancer and how it is being treated by surgery and neoadjuvant therapies. I'm going to talk a little bit about future directions and also, of course, about some of artificial intelligence development in endoscopy. So let me start with principle of cancer. As you know, normal cells, they divide 1 upon 2, and they have the division or the growth of these cells eventually stops. Different to cells with cancer in which the DNA is damaged, actually they don't have control in their growth. For most of GI cancer, alcohol, smoking, HP, and HVP are known as class 1 carcinogens. As you know, alcohol and smoking very much related to esophagus cancer, stomach cancer, colon cancer. HP is a type 1 carcinogen for stomach cancer and HVP for liver cancer. There are other risk factors like obesity that are not class 1 carcinogens, but very important factors. So Dr. Follman in New York in 1971, he proposed this phenomenon of angiogenesis, basically composed of cancer cells that attract vascular vessels from the host, and they start to grow until eventually they take all from the host, blood, oxygen, nutrients, and the patient eventually die. So how is neoangiogenesis linked to endoscopy? Well, in 2005, there was a breakthrough in cancer development and endoscopy. And here I have brought three main articles. I was very lucky to be part of these developments more than 20 years ago at the National Cancer Center in Tokyo. And there was two big movements here. Number one was the development of magnifying chromendoscopy that was actually having like a microscope in our hands through the endoscope. And the other one was the development of endoscopic submucosal dissection for the treatment of early cancer in the stomach and in the colorectum. So these two, let's say, developments linked together with the angiogenesis. And the reason is basically this. These are tumor tissues in the colon. And you see here that when we did here, that was performed by Dr. Sano, one of my colleagues at the National Cancer Center, he used monoclonal antibodies against CD31 in endothelial cells. And we learned that normal cells, of course, they have vessels and hyperplastic tissue as well. But adenoma and cancer has an increasing number of vessels, and they change in density and number in cancer lesions. So we were able to see this actually by endoscopy. If you see here, type 1 lesions, of course, they have vessels, but are not visible through the human eyes. And then type 2 lesions has like a mesh capillary patterns. And the more the lesion grows and transforms into malignant, of course, what Dr. Feldman has developed is being seen by us through endoscopy. We were able also to categorize this in benign, premalignant, early cancer, and deep cancer. And this is known as the Sano-Emura classification for the MVI of colorectal polyps. So what about endoscopic treatment of all these lesions? I have some videos here. You can see here a very small lesion, less than 20 millimeter. And this one, which is actually 80 millimeter. This is the way we treat by endoscopy these lesions by polypectomy. And this is called endoscopic mucosal resection, EMR. Both are with a curative intention, and this is one of the ways we can prevent colorectal cancer development. These specimens, of course, goes to pathology, and the final, either the patient is cured or not cured, just comes with the pathology report. So what about these type of lesions? These lesions are, number one, very difficult to find. They are called LSTs, lateral spreading tumors, that they goes like a carpet spreading over the mucosa of the colon. And as you see here, the key for diagnosis, for early diagnosis, is the neoangiogenesis phenomenon that increases vascular density over the lesion, and then we are able to see this as a redness spot. If we use MVI, again, we can easily trace the margin of the lesion and see the vessels. In this case, is being categorized as a 2A, that means early colon cancer, and we can treat these lesions by endoscopy with a curative intention. So what is actually ESD? That I was part of this development more than 20 years ago in Tokyo. We have a superficial lesion just invading the mucosal layer here, and using very special devices that we call knives, endoscopic knives, we are actually able to dissect through the submucosal layer, which is here in gray. and remove the tumor in one block. This facilitates histological assessment by pathology. And doing this, we are giving the patient a high chance of cure. These are the accessories we have available to operate, let's say, operate at the endoscopy room, all these kind of lesions. There are so many different knives, lifting agents, and cups, CO2, and endoscopes that we need to accomplish these procedures. Okay, for some reason this is not moving, but it illustrates how is endoscopic mucosal dissection for this kind of tumors. So as I said, the final curative result is coming from pathology. This, in this case, there was a low-grade dysplasia, and the muscularis mucosa was preserved, as you can see here. And the submucosa also was preserved. In this case, was a curative resection, and the patient was cured from that early colorectal cancer. So when we compare ESD with a traditional methods like EMR, there are huge differences. And block resection, complete resection, and local recurrence are very much in favor of endoscopic submucosal dissection. I need to say that this type of method requires a long curve and special training, but it's been proven the best method for treating early colorectal cancer and stomach cancer. However, the number of perforation compared to EMR method or traditional method is higher, but in expert hands, this can be fixed at the during the procedure in the endoscopy room, and we don't need to run to surgery and ask for help to colorectal surgeons. This slide summarizes the advantage of ESD over surgery, or basically, number one, no admission. So these patients are not coming to the hospital. They are discharged the same day. It's a painless and incisionless procedure. That means no need of laparoscopic instruments. The patients, they don't need any antibiotics, and is actually an organ preserving alternative for the treatment of early GI cancer. So as the conclusion, as for now, we can say that based on these amazing developments in endoscopy, imaging, and endoscopy treatment, GI cancer can be prevented and cured by removing premalignant lesions, let's say polyps, and early cancers. Unfortunately, GI cancer is very prevalent and has a lot of mortality worldwide. Colorectal cancer and stomach cancer are among top 5. Thank you. You see that top 5 cancers are lung cancer, breast, colorectal, and prostate, and stomach. And mortality is also, putting colorectal on 3rd place and stomach on 5th place. So there is much to be done in terms of reducing incidence of GI cancer and, of course, mortality. And for this, cancer screening is the most important strategy. In relation to EGD, I will say that this is the best method to screen the stomach. It's part of a patent that was filed in 2012 by my team, and is actually reviewing all the, examining the stomach from in a clockwise manner from the anterior wall to the lesser curvature to the posterior wall and the greater curvature in a way that no blind spots are left behind. And perhaps this is the best method to screen the stomach and to reduce cancer and mortality. You can see here that to every single area, a number has been allocated, as well as the name of every single station. The exam just ends up in the angularis incisura, which is a place where early cancer tends to grow. This method was recently endorsed by the World Endoscopy Organization, and at the end, we may have all the esophagus that was not presented in the video, the hypopharynx, the stations in the stomach, and the duodenum, 27 and 28 stations. I think this exam can be accomplished in about 3 or 4 minutes. And is the best way actually to screen the upper GI tract. So what's the difference between premalignant lesions in early cancer? This is the Correa cascade, a Colombian pathologist that developed this phenomenon that starts in atrophy. You see here how the vascular pattern is very visible. That means that there is no mucosa left in the lesser curvature. And later on, this transform into these yellow-green plaques or nodules that are known as intestinal metaplasia under MVI. These patients are usually infected by HP, so there is a way to also to take biopsies from the stomach, not only to diagnose or rule out malignancy or premalignancy, but also to take samples for HP analysis. And it is demonstrated that treating HP, this cascade is being stopped. So how about early gastric cancer? Can you see it here? This is actually not an erosion. It's an uneven surface in the gastric antrum right here. And by endoscopy methods, we are able actually to delineate the margin of the cancer and make a better staging. Now, we will find out the vascular irregularity using magnifying endoscopy. And you will see how the vessels, again, going back to the angiogenesis phenomenon that we can observe through endoscopy, this will be very evident that vascular irregularity is seen around here. And that this is surrounded by intestinal metaplasia here. This is a typical finding using magnifying endoscopy of an early gastric cancer. So when evaluating the lesser curvature of the stomach, we should pay attention to very small lesions that looks like erosions, benign erosions that are actually cancer. I have brought an example here that is located up to the third portion of the stomach. Right here. This is not an erosion that can be treated by PPIs, but a cancer. Why is a cancer? Because it has a hypervascular density. You will see this here. If I put a little bit drops of water to increase contrast and imaging, here, this is an early gastric cancer. So how can we treat these lesions? Endoscopy, again, is the best method to treat this patient. These patients, you see here, early gastric cancer, and this is the method we go and resect the lesion completely and block and send this to pathological analysis. So we proved about 10 years ago in Colombia that this method is highly effective for treating these lesions with a high R0 resection rate. That means Q resection rate with a very low percentage of perforations. Here, these results were compared to the best results from Japanese institutions and were actually comparable. So what about deep cancer? So advanced gastric cancer needs additional treatment, that is surgery and adjuvant therapy. You see that when gastric cancer is in advanced stage, the whole stomach needs to be removed and the esophagus needs to be connected to the jejunum. This is a major surgical procedure that we don't want to have in our patients, but actually endoscopic resection and surgery has comparable survival, as you can see here. And when it comes to complications rates and cost, ESD has a lower hospital stay, lower complication rate, and of course, lower cost. You see here that ESD is 3.5 times less costly than surgery. What's the future direction? I think this tends to be into artificial intelligence. We were able to demonstrate that a novel learning, deep learning model was effective to actually to differentiate stations or to recognize stations, but there is still pending work to be done. That means differentiate, let's say, area or station 6 from 26 on 28. I think this is a research that can be done here at that actually was stopped years ago in Colombia because financial situation. So what about the colon? Of course, colonoscopy is the way to go. And as you know, in our days, 45 years is the threshold for a screening colonoscopy in all over the world. This is LST lesion in the ascending colon that can be diagnosed through colonoscopy and also treated by block resection, aiming curability. So premalignant lesions and are like this. Very difficult to differentiate with this kind of endoscopy means by if we do use magnifying chromoendoscopy, we can see this. And of course, the pit pattern is different. This is kind of a brain pattern. We call this brain pattern is an adenomatous polyp, and this is an hyperplastic polyp. So these polyps can be left in the colon in situ, so they don't need treatment because they don't have any malignant potential. But this transform into cancer and they need to be resected. So these lesions are, we have about 4 or 5 lesions here at that we have sent it as an abstract for the next DW, are actually procedures that can be accomplished, even they are inappropriate tattoo around the lesion. You see here how the lesion was nicely resected, and there are black spots under the lesion, even though these patients can go to the endoscopy room instead of surgery. We were able also years ago to demonstrate in Colombia the effectiveness of ESD in terms of high en bloc and R0 resection rates. And in relation to cancer, again, as in the stomach advanced cancer, these patients needs to go and be removed part of the colon and what we call right hemicolectomy, let's say, if the colon is in the right side, and then make an anastomosis with the small intestine. When we compare ESD with surgery, ESD have lower operation times and stay, but also comparable survival rates, as is shown here. What's the future directions in this cancer? I need to say that in our days, there is an overwhelming production of articles regarding organ preservation when when it comes to rectal cancer. In our days, rectal cancer is being treated, number one, with chemoradiotherapy, and then with surgery. So you see here that there are, this is are very recent articles. So very recently, that this is a publication that I submitted last year. We propose that endoscopic treatment of advanced rectal cancer, this can be an alternative after chemoradiotherapy, is basically these tumors that are deeply embedded in the muscle layer can be resected and blocked by endoscopy and by using these knives. This is one example of this procedure. As you see, of course, there is an ulcerated lesion that can be resected and blocked. So I'm trying to describe here the method of doing so. So what I'm doing here is that I cut the internal muscle layer, which is the circular, and then go to the deeper mucosa layer and cut it. And I have accessed the mesorectum. This is the first case in the world published regarding this method. You see there that there is a lot of fatty tissue that goes along with the specimen. What I'm doing here is that I'm resecting the remaining mucosa. And by endoscopy, we are able of en bloc resection of advanced rectal cancer. That's the mesorectum. So this patient was admitted for 3 days. He received antibiotics, broad spectrum, and went home after 4 days without any complication. So this is the specimen. You can see here the adenocarcinoma, just embedding deep into the muscle layer, but not trespassing actually the inner muscle layer. The submucosa in green, the circular and the longitudinal and the perirectal fat right here. So if you ask me about future directions in this topic, I will say that one of the hypotheses is that endoscopic mesorectal dissection is more cost-effective and alternative than transmesorectal excision and even local excision for T2 and T3 rectal cancer with comparable survival. This is just my idea. It's just an hypothesis that needs to be discarded or proven. For this, I think this has never been done, and I think this is a potential, way to go here at that T2 and T3 rectal cancer goes first for chemoradiotherapy, and we can have, 2 arms, one for transmesorectal excision and the other for this method. And at the end, compare outcomes, postoperative adverse events, overall cost, complications, etc. So when it comes to artificial intelligence in endoscopy, I have brought a few videos here from my own experience. One is lesion that is benign, very benign, that goes up to green here. The system goes green here, so that means the lesion is benign, hyperplastic, and when the screen goes with this yellow color around means adenoma. So that means that we need to resect this lesion probably by polypectomy because the size. And here is a live demonstration a few years ago that I conducted to show the benefit of AI in the colon.
Can you see any lesion?
I'm sorry.
Now
I cannot recognize.
There is no apparent lesion using white light, but if I activate the cat eye, I think it will just help us as is showing now, this small nodule. And then if I get a closer view, it's obviously a very small LST.
And the system just categorized this as a neoplasia, and of course, it needs to be resected in order to prevent cancer development. So I believe that we don't have that this system is still here at UM, but it is available broad worldwide. I believe that the systematic application of AI for the detection and characterization of these lesions is going to be, of course, the standard in the near future. So in summary, I will say that through endoscopy and through this tremendous, wonderful development of endoscopy for diagnosis of polyps, for let's say premalignant and early cancer, but also with the development of advanced resection methods, providing curability to our patients, and all this link through angiogenesis, that is actually we are able to see the angiogenetic process through endoscopy. We can actually prevent cancer, GI cancer, and treat with a curative intention. But of course, this needs to be, we should do a great effort for screening and early diagnosis. I think these are key for success. Remember that colonoscopy should be done at 45 years, regardless you are in a high risk or an average risk. And in our days, EGD is also promoted at 45 years old, especially for high risk individuals. That means immigrants coming from Asia, and immigrants to the States coming from Asia, let's say Japan, Korea, and also from Latin America, let's say Colombia, Peru, Costa Rica, Brazil, Chile. So to those individuals, we need to provide them for a screening EGD. Also that ESD, endoscopic submucosal dissection, is a preferred treatment option for early stage GI cancer. As I show, it provides, incisionless, painless, no admission, and organ-preserving alternative to surgery. And that the upcoming research in terms of AI in the stomach and endoscopic mesorectal dissection as an organ-preserving alternative for rectal cancer will expand even more the endoscopic applications for this, for gastrointestinal diseases. So thank you very much.
Thank you, Dr. Emura, for that beautiful presentation. I can't help but have heard one of our chief residents behind me who's going into GI, who was like, it was watching like, I don't know what, he was, ooh. So calm down, calm down. No, it was really excellent. How do you, can we turn the lights on? Is there a way? Oh, Dr. Deshpande, thank you. Oh, great. How does one balance, if I were to go in for a screening procedure, I would want to be certain that the endoscopist was taking all the time they could to find all these subtleties and these subtle lesions. And at the same time, you have the vice president for operations screaming down your back, get in and out of the room as quickly as possible. How do you balance the need for a thorough evaluation, and what is the standard for being fastidious and being sure that you don't miss these subtleties?
Thank you, Dr. Wise. I think that's a tremendous important point. In terms of timing, I will say that there are methods to evaluate the standards in colonoscopy. Let's say we need to take at least 6 minutes from the cecum to the rectum and take, enough time, at least 6 minutes to evaluate the inner lining of the colon in 360 degrees and also behind folds, aspirate the remaining fluid and try to use high definition imaging, trying to find these subtle and diminutive polyps that tend it could be cancer. Also in the stomach as well, we may use high definition imaging, and in our days we can clean up the stomach and the esophagus for facilitating this. I believe that there is a balance, of course, between timing of the procedure and turnover of. We used to have a long list of patients, but also it's a matter of practice and experience trying to do the best and try to deliver to our patients the best, high quality procedure in the shortest time possible. So it's a matter of training and practice, I believe also, along with high definition imaging technologies. And AI will help us a lot, Dr. Weiss. I think that, yeah, well, the point here is that if we don't locate the camera right into the point where artificial intelligence is able to help us, there is no cancer diagnosis. So we need to increase our ability to look over the folds, to wash, and to actually to screen the inner lining and allow AI in the future to help us with diagnosis and even more differential diagnosis of polyps.
I think 3 years is enough for a fellow to get that all down. Dr. Sussman.
That was great. Thank you, Dr. Emura. So to bring some of this perspective to the a general GI provider or to the primary care providers in the audience, we used to have this reflexive paradigm that if it was an apparently unresectable polyp or growth in the stomach or colon, we biopsy an abnormality, and the pathology comes back as adenocarcinoma or high-grade dysplasia, and it looks challenging to remove. We used to have this reflexive, let's go to surgery. And then as soon as a patient sees a surgery, they reflexively have surgery. What kind of features are there that a GI doctor might see during these procedures? Or probably more importantly for this audience, if a primary care doctor has a patient who's told they need surgery, what kind of features might they be looking for on an endoscopy report that might tell them they could potentially benefit from either a complicated endoscopic mucosal resection or an endoscopic submucosal dissection for some of these lesions? What might they be looking for, and what might not we be reporting on our reports that might give that information to you?
Yeah, thank you, Dr. Sussman. That's a very important point. I will divide my answer in two. Number one is very subtle lesions, diminutive lesions that can be misdiagnosed into erosions or gastritis. This lesion needs to be, evaluated carefully. We need to, wash out the inner lining, either of the colon, esophagus, or colon. And always when there is suspicious, you may take a biopsy. I think biopsy is the gold standard and is above endoscopic imaging. Certainly, by using endoscopic imaging, we're able in our days to do a precise diagnosis. But if you, general providers or internal medicine doctors, when there is a suspicious or even you may don't know what is that about, what that is lesion about, you may take a biopsy. On the other side, there's huge lesions, these huge ulcerated lesions that are hard. When I say hard, that means that I don't need to touch the lesions to feel or to make sense in my mind that is hard. It's like looking at this table, right? It's hard. I don't need to take it, to touch it, to that, something in my brain says is hard. It's same in endoscopy. So when lesions are hard, ulcerated, with easy bleeding, of course, these lesions are probably an advanced cancer. And also we need to take biopsy samples to make the insurance cover that procedure for either for oncology or a surgical procedure. So I think that, in summary, number one, keep in mind the biopsy is still the gold standard for both type of lesions. I will say in addition that these lesions, the advanced lesions, need to be tattooed in some cases. And this is very important to do according to guidelines that says that tattooing should be either proximal or distal of the lesion, but at least 5 centimeters away from the lesion. So that perhaps is my answer to your question.
Dr. Punjabi.
That's curious. The esophagus, the esophagus and colon are very structurally different with regards to the mucosa itself. Vascularity of the stomach is very different than the esophagus and colon. So I'd love to have you comment on, when you were showing these procedures, I was worried about the complications rate, particularly with perforation and bleeding. So number one, is there a difference in perforation, bleeding, stomach, esophagus, colon? And is there a difference in perforation rate and bleeding across the three areas that you can use EST on?
Yeah.
Okay, we need to repeat if you could repeat the question, Dr. Emura. There are two questions.
So the question is, what are the complications rate of this endoscopy procedures in terms of perforation and bleeding? And number two, if there are differences between esophagus, stomach, and duodenum, correct? And colon. Okay, so number one, in our days, I mean, remember that this developments has been for 20 years out there. I've been very lucky to be part of the very first procedures in Tokyo. I will say that, of course, through 20 years of practice and experience, the adverse events has been lower than before. In our days, I will say that between 1% or 2% of cases in expert hands had delayed bleeding. And this is quite common or similar to esophagus, stomach, and colorectal, maybe 2 or 3%. Perforation has been dramatically reduced over the years, and it is about 1% in expert hands. So what happened with this? Are we able to fix the complication rate during the procedure? The answer is yes. There are several instruments like endoscopic clips in our days and many other developments in the GI arena that we can use to provide the patients with, solving the complication during the procedure and not taking the patient to the operating room or calling our colleagues, very esteemed colleagues, colorectal surgeons, to help us a hand. So in summary, we are able in our days to deal with that complications during the procedure.
Last question, Dr. Oh, sorry, did you want to say
No,
something?
I think that
That answers the question.
that's the answer, yeah.
Okay.
So, thank you very much, and I think you've really kind of, like you really said, a lot.
Thank you.
What's resectable endoscopically.
I think you've shown the moving of the needle endoscopically, but what's resectable in cancer. I was hoping you could comment, a lot of these techniques, which you've shown beautifully for neoplasia, some of your experience on how you can move some of these techniques into non-malignant things, inflammatory diseases, motility diseases, and others, and how some of these experiences that start in cancer have been able to translate, and how maybe the future of some of these other diseases that aren't cancers might be on the horizon of doing things endoscopically that were traditionally outside of what we can do.
Wow, thank you, Dr. Despande. Yeah, I mean, in fact, this ESD development through 20 years had expanded through other types of GI diseases, benign diseases. That is called third space surgery in our days. It translates into curative treatment by endoscopy through, let's say, achalasia, through a procedure called POEM, through a center diverticulum that, as you know, as here up is an opening of the cricopharyngeus right up here that causes dysphagia, right? It's the procedure, the endoscopic procedure, which is actually, again, an expansion of the ESD development, is called Z-POEM, that is Senker POEM. And there are so many others, like treating of gastroparesia. And even I have the privilege to have some patients here at with patients that needs to be ruled out for Hirschsprung disease. And we were able also to invade the rectal wall and take full thickness biopsies for this benign disease. That means, again, not necessarily premalignant lesions or polyps or cancer, early cancer, but also applicable, expanded to benign diseases.
Thank you, Dr. Emura. I thank everybody for participating in today's grand rounds. The information for MEC and MOC is in the chat, and as you exit, you can get the information as well. Look forward to seeing everybody next week. Everyone be well.